then we can begin. Yes, so welcome everybody once again to the trial class of First Aid AMC. I'm your mentor, Dr. Rouge, and I will be discussing some of the sample questions today, which have been which most of the people are coming across recently in March and April. If you have any questions, you can raise your hand or you can basically type in the chat and I will be answering that. Okay, and don't worry, this is a very doable exam. You can definitely pass it in the first go. You just need to know how to tackle the questions, how to consolidate your theory, how to do the maximum questions as you can. That is the important thing. That is the key about this. And also, if you would go through all the videos and all the discussions and all the theory classes of this session, I'm 100% sure you'd be able to pass it in the first go. Okay, so let's begin. Yes. So the first question is, let me get my pen. A 65-year-old female presents to the clinic with a history of hypertension, acute coronary syndrome, and palpitations. He reports feeling of occasional episodes of heart racing and shortness of breath, and ECG shows atrial fibrillation with heart rate of 130 beats per minute. What will be the long-term management? Okay, so as we can see, whenever you see a question in an exam, the important clues that you should not miss are, first thing, age of the patient. Always see like what is the age of the patient, then gender. Most of the time they would give you the gender, either male or female. And again, where is he or she presenting? If she is presenting in the ER, or if she's presenting in a GP clinic, or like where is it happening? Okay. And after that, then we will go to the symptoms. So she has a history of hypertension, acute coronary syndrome, and palpitations. And at this point, she's presenting with heart racing and shortness of breath. So the GP did an ECG, which showed atrial fibrillation. So now we know the diagnosis already. So this is out of the way, which is good. Now they're asking what will be the long-term management. Okay, so the options are atenolol, apixaban, Loprin, or statins. What do you guys think will be the answer to this question? As we know, atenolol is a beta blocker. It's like propranolol, atenolol, all that. Apixaban is your direct acting anticoagulation agents. Loprin is like your aspirin, antiplatelet drug, and statins are, we all know, these are statins. So what do you guys think will be the long-term management of this question? Okay, so a lot of people are saying A, atenolol. A couple of people are saying B, which is your apixaban. Okay, so let's explain. Let's go through the answer. Basically, atenolol or your beta blockers are not your long-term management, okay? These are used only when a patient has a very high heart rate. In order to control the heart rate, you will use beta blockers, okay? But as we can see that this patient does have a higher heart rate, but the problem here is not that. Never miss the last line of your question. You have to see what they're asking. They're asking for the clue here is long-term management. They're not asking what are you going to do now or at this moment, because if they would be asking what to do now, we would have gone for atenolol, which is your beta blocker, because at this point we are going to control the heart rate, right? And after controlling heart rate, we might want to control the rhythm as well. But this is not the question. The question was, what will be the long-term management? And long-term management, when they ask, we are going to talk about your CHA2DS2-VASc score. Does anybody know? Do you guys have an idea about CHA2DS2-VASc score? Yes. So this is because of your CHA2DS2-VASc score, in which you're going to see if the patient has a history of hypertension, chronic heart disease, cardiac disease, if the patient has diabetes, previous history of score, or a stroke, or like any vascular disease, and age of the patient. So based on that, if the CHA2DS2-VASc score is more than or equal to 2, we are going to start this patient on apixaban, rivaroxaban, or any of the direct acting anticoagulation agents, okay? But if the patient does not have, if the patient's score is less than 2, or let's say 1, then we can just give him a heparin. Okay, but if it is less than 1, then antiplatelets or like any of the anticoagulating agents are not needed. So the answer is apixaban. There are a couple of websites here linked to this. I will just open it for you guys so that you will have an idea about how to tackle such questions. So there you go. So as you can see here, whenever we are seeing atrial fibrillation, this is, by the way, whenever you're preparing for the exams, the very important thing is that you need to be updated with the recent updates. The very useful websites that you should be checking at least like once a week to see any updates happening is RACGP website, this one, or basically they call it Australian Journal of General Practice, AGP. So these are the websites which are your reliable resources. So as you can see that this is very common, then they're talking about how the patient will present. So the patient is presenting with palpitations and heart racing and all those features. And then here, if you see what is the systemic approach to the management of the patient. So that is, you're going to go for rhythm control and then rate control. And then you go for anticoagulation for stroke prevention. Long-term management is your stroke prevention, okay? So these are just some of the risk factors that are reversible. So if the patient has any of the reversible risk factors, you will just like tackle those. But if not, in that situation, the patient will need a long-term management in order to prevent the stroke. So this is again just okay, so this is again flow chart of like once you have diagnosed atrial fibrillation, you're going to see if it is a reversible cause or if it is irreversible cause. If it is reversible, we are just going to go for like control that reversible situation. And then we're going to go for rhythm control first, which is your cardioversion or medication. So what are the medications that are commonly used for rhythm control? They are like flecainide, you have cetalol, you have amiodarone. These are very common medications that are used for rhythm control. But if the rhythm is fine, but the patient has a rate which is higher, and this most commonly happens when the patient is presenting in a GP setting. If rhythm is the problem, patient will mostly present in the ER, okay? If rate is just the problem, then the patient will have like, I have palpitations, I can feel my heart racing, and he will present to the clinic. So in this situation, beta blockers are your first choice. And then other than that, you can use calcium channel blockers as well, okay? And after you've done all this, what is the important thing that is relevant to this question is how to prevent stroke. What is the long-term management? So stroke prevention is a major aspect of atrial fibrillation, and Charpas score is widely used for this. What is Charpas score? Here it is. So congestive heart failure will have 1 score, hypertension 1 score, age more than 75 will have 2 scores. Diabetes 1 score, stroke or transient ischemic attack, like previous history of stroke or in TIA, 2 points, okay? Vascular disease will have 1 stroke, and if age is more than 65, this will have 1. So more than 75, 2, more than 65, 1 score, okay? Okay, so if it is 0, oral anticoagulation is not recommended. But if it is 1, they should be considered, but not like this. At this point, it depends on the patient's situation, like the age of the patient and how high of a risk he has of getting a stroke. But like if it is more than 2, then DOACs must be given, okay? So that is the reason we are going to give this patient apixaban or rivaroxaban. In the same way, I have another article which will also be discussing about this. So this is again the management about how to do that. So after doing the diagnosis, this is your Charpas. So based on this, as you can see, here are the points, and here's the risk factors. And based on this, you're going to suggest the patient if the patient needs anticoagulation or not, okay? So anticoagulation is required. So 70% of the patients, it will reduce the relative risk of stroke. That is the reason. So this is again another authentic website, NPS Medicine Wise, and Australian Prescriber. So this website is also reliable. You can get your resource from here as well. Okay, I have attached the links to these websites in the in your like people who will be joining our course will be receiving the recording as well as the PDF and the this presentation as well. So all of these links have been attached to that, so that you don't have to go through multiple websites and basically, you know, fish for your own self on where to find these resources. As you can see, these are the links that have been attached, and there's another one. You can go through this. Okay. So this here again from the website, I have like copy pasted this chat score for you guys for the reference, so that you don't have to open the website and go through all that. And this is just a layout or flow chart on when to prescribe oral anticoagulants and when to not. So if 0, it is not recommended. 1, consider. More than 2, you have to recommend it. And that's the reason we are going to go for apixaban in this patient. All right. Any confusion so far? Is it clear, all of you? Good. Okay. Cobra is asking, in case of MS and AF, but CHADVA score is 0, what should be the answer? Okay. Okay, Cobra, if the patient has mitral stenosis and he's presenting with AFib, CHADVA score is 0, you do not need to give prescribed anticoagulation at that point, because MS is not considered congestive heart disease or congestive heart failure, so you do not need to do that. Yes, okay. So I hope it's clear now. Let's go for the next question. Okay, so the question is, a 53-year-old man comes to the GP clinic with father, history of prostate cancer. He's concerned about having cancer and his friend told him to get screened. He's asymptomatic. What would you do? Reassure there is nothing to worry about. Do blood test for PSA. Do a DRE. Explain to him about pros and cons of DRE and PSA. Screen him every 2 yearly. Yes. Okay, let's see. What do you guys think? Okay, a lot of you are getting the right answer, which is very good. Okay, let me explain how it works. So as you can see that this patient is, first thing, age 53, and he's coming to the GP clinic, so not an emergency. And his father has a history of prostate cancer, not him. And he's worried that he might have cancer as well, right? So, and he's asymptomatic, which means he doesn't have any of the nocturia or like any of the like urgency, frequency, or anything like that. Okay. So, what do the guidelines say? This question is not about your like concept. Okay, it is more about guidelines. They're asking what is routine in Australia. How do you work with a patient who wants to get screened? Okay, because currently in Australia, there are no guidelines, like no set guidelines or basically screening for the patients who have a family history of prostate cancer. Okay, but just like we have breast cancer and cervical cancer, we screen for them, right? But in general population, we do not screen for prostate cancer. So the first thing that you're supposed to do at this point is you're going to explain to him about the pros and cons of DRE and PSA. Whenever a patient, okay, because why do you think this is happening? The problem is if you do a DRE and if you do a PSA, if the results are false and positive, you might want to get into an unnecessary treatment, even though the patient does not have cancer. He might be too worried about it. The patient might want to get treatment, and you might even want to give him treatment at that point. Okay, so this leads to unnecessary worry, unnecessary treatment. That is the reason when a patient presents to you, you have to tell him that I don't have a problem doing your DRE and PSA, but there are researchers, there are results, there are we have data that suggests that if you're doing DRE and PSA, there might be false positive results which need to unnecessary treatment. Okay, so once he accepts that and he still wants to go ahead, then you go for DRE first, And after that, you go do the blood test for PSA. You can do that on the same day as well. Before, there was a guideline that you cannot do PSA on the same day as DRE, but it has been renounced now. You can do DRE and PSA on the same day, okay? And you're obviously not going to reassure him that there's nothing to worry about, because he's coming to you because he's concerned. So you have to answer to his concern, okay? And once you have established the facts and there's something wrong in DRE and PSA, then you might want to consider screening him every 2 yearly. First, you have to explain the pros and cons to the patient, okay? So all of these answers are like in the guidelines, but they're in different steps. So first thing, explain to him about pros and cons of DRE and PSA. So read here. For men aged 50 to 69 without a family history of prostate, the benefit and harm debate for the prostate cancer using PSA test is unclear and open to individual interpretation. Australian guidelines support informed decision-making about prostate cancer screening based on personal circumstances. Since the decision to have prostate cancer screening is a personal one, it is up to the individual to request testing from their GP, okay? Now I have some articles as well, which would answer this question for you guys. So let's go through them. Okay. So let me share this. So as you can see, there are a lot of people who have been who are at a risk of developing prostate cancer and all that, and who are being diagnosed with this. But the important thing is here. Yes. Some studies suggest that PSA reduces mortality in population. The test picks up large number of cancers that would have caused no symptoms or harm in the patient. This is known as overdiagnosis. Overdiagnosis of prostate cancer can lead to unnecessary treatments that have side effects such as sexual impotence, urinary incontinence, and bowel problems. See, this is the reason. So it is important to balance the potential benefits of detecting prostate cancer early against the risk that detection and treatment may not be necessary. So treatment may affect your lifestyle. That is the reason. First, tell them these pros and cons. After that, if he still wants to go for that, you can go ahead and tell the patient that, okay, we can do the screening for you. So in the same way here as well. Yes. So no national screening program for the early detection of prostate cancer, as you can see here. Doctors have different opinions. So there is concern that testing healthy men will cause unnecessary harm and lead to treatments that may not offer long-term benefits. Treatment for prostate cancer can leave men with side effects such as erectile dysfunction and continence issues. So testing may identify fast-growing aggressive cancers. Okay, so what are you going to do? Weigh up all the risks and benefits before deciding whether to be tested for prostate cancer, particularly if you don't have any symptoms. So pros and cons. Tell the patient about pros and cons. Then if he wants to go ahead, you go ahead with the testing and all that. Is it clear? Yes, guys, do you think it's clear now? Okay, good. So I'm sorry. Yes. So as you can see here. Yes. So as you can see here, it's also written, men who are considered, so a PSA test, and even here, men who have a father or a brother who has been diagnosed with prostate cancer have 2.5 to 3 times higher than average risk of developing such a disease. Such men, after they have been informed about the benefits and harms of testing, who have decided to have undergone regular testing for prostate cancer, should be offered PSA every 2 years. But first thing, inform about the benefits and harms. After that, you can go for that. Okay. Okay, now the next question is, a 50-year-old male with a history of heavy alcohol use presents to the, age, 50-year-old male. History is heavy alcohol use, presents to the ED with severe epigastric pain radiating to his back, nausea, and vomiting. Physical examination reveals tenderness in the upper abdomen, and the patient appears jaundiced. Lab investigations show elevated serum amylase and lipase. What is the diagnosis? Acute pancreatitis, aortic dissection, hepatitis, or cholelithiasis. What do you guys think? Yeah, excellent. Everybody's getting it right. Yeah. All of you are almost prepared for the exam. That's amazing. Okay, yes. So acute pancreatitis is the right answer. Why? Because look at the history, very suggestive. First thing, he's a 50-year-old male patient. Males have are more commonly at risk of developing acute pancreatitis, and he's an alcoholic. So wherever you see ethanol, ethanol is associated with acute pancreatitis, and he's presenting with severe epigastric pain. Now, this character, epigastric pain, which is radiating to the back, very suggestive of acute pancreatitis. Then he has periabdominal tenderness, and then he appears jaundiced, which could also be because of this. And again, another important thing, serum amylase and lipase. Serum amylase and lipase are directly associated with your pancreatitis. So that's the reason we are going for acute pancreatitis as the correct option. Good. Okay, so let's see. Yes, so acute pancreatitis, and this is the clue. Serum lipase 3 times the upper limit of normal is suggestive of pancreatitis. It is 82 to 100% sensitive. So if they would have given you the option of either serum lipase or serum amylase, go for serum lipase. Serum lipase is more sensitive for acute pancreatitis as compared to serum amylase. And it remains elevated for a longer period as well, right? So that's the reason it has higher specificity. Okay, then there are some articles about acute pancreatitis or what to expect from them. Let's look at these. Yes. So here is acute pancreatitis, and there are some of the how to what could be the cause, because it is an acute inflammation of pancreas, so it will happen suddenly. But if it is severe, it has a mortality rate of over 20%, which is very high. So it is a kind of an emergency. This patient will present to the emergency department. Okay. Symptoms are very suggestive: abdominal pain, generalized, severe, may radiate to the back that we saw in our patient. Other than that, there could be nausea, vomiting, and diaphoresis. Okay, then risk factors. Yeah, this is the risk factor. So very common, very main 2 risk factors are gallstones and ethanol. So both of these are associated with acute pancreatitis. Then first, as soon as you see the patient, what are you going to do? Initial resuscitation, which is your ABCs. First, once you have done ABCs, what could be your differentials? So what other things which can mimic acute pancreatitis? What other conditions? Acute coronary syndrome, which is your myocardial infarction or angina, aortic dissection, perforated viscous, esophageal rupture, pancreatitis or ectopic pregnancy, or abdominal aortic aneurysm. All of these can somewhat present with the similar features. So that's the reason you should, again, but this is more for the practical use, not for the exam purpose, but just in case you want to know, these could be the differential diagnosis for that. So after that, you're going to do the detailed assessment, and then serum lipase is the suggestive factor. It is the diagnostic factor for your acute pancreatitis. And after that, you're going to treat the patient. How are you going to treat it? There is Glasgow score. So once you have determined this is the Glasgow score. If it is more than 3, refer the patient to ICU. So what could it be if partial pressure of oxygen is less than 60, or basically less than 92%? Of oxygen saturation, age more than 55, white blood count of more than 15, calcium less than 2, urea more than 16, lactate dehydrogenase more than 600, or AST more than 200, albumin less than 32, or sugar glucose more than 10. All of these is, if 1 point is for each. If it is more than 3, you're going to submit the patient to ICU. Other than that, you can keep the patient in the ward and keep the patient nil by mouth, and hydrate the patient and see if he gets better. Okay, so this is how. Then there is another article about the same thing. Let me show you that one as well. Yes. So this is the same thing again. Like, what are the features? Sudden severe epigastric pain, nausea, vomiting, fever, all that, and what could be the cause? So the cause is gallstones and heavy alcohol consumption. These two are the main causes. And then after that, how to diagnose it? Diagnosing, other than that, extra and all that, the main thing is the enzyme. So lipase and amylase are the enzymes that you're going to see. And after that, for acute pancreatitis, you admit the patient to the hospital, and sometimes they might want ICU care, like I told you, if Glasgow scored more than 3. Okay, and then you will give them IV fluid, pain relieving medication, and sometimes antibiotics. So just this, there's no specific treatment for acute pancreatitis. Okay, all right. Now, is that clear, you all? Any confusion, any question? Okay, good. So HAUs is saying why calcium? Because if calcium is low, you can develop tetany. Okay, so in this situation as well, which means you have metabolic disturbance going on. If your calcium is low, which means your sodium, like lipase, is already high, your amylase is high, and calcium low suggests kind of metabolic disturbance or electrolyte disturbance. So that patient is also considered critical, and we are going to treat that patient in the ICU department. Yes, yes. If the jaundice is associated with pancreatitis, Rabel, we are going to go for the same treatment, because here jaundice is not because of liver problem. The jaundice is because the pancreas got swollen, and the bile, which was like the duct, which was supposed to concentrate the bile and do all that, the cystic duct and that pancreatic duct, it got narrowed down, okay? Because, there is ampoule of water through which that is opening. If there is swelling of pancreas, it will narrow that down. And that's the reason there will be bile accumulating in the body, causing jaundice. So if the jaundice is because of acute pancreatitis, yes, you're going to do the same treatment. However, if it is associated with liver problem or something else, in that situation, of course not. Then you're going to go further for whatever is the reason or the cause of the jaundice. Okay. Okay. So these are again some of the same things, the differential diagnosis that I've mentioned here. So for you guys to know what could mimic acute pancreatitis. Okay. Now let's move on to the next question. Okay, a 35-year-old male patient presents to his GP complaining of difficulty swallowing and feeling like food is getting stuck in his throat. He also experiences occasional episodes of chest pain and heartburn. He says he also has eczema family history. What is a possible diagnosis? Okay, let's go back. Age, 35-year, male patient presenting to the GP, complaining of, now what is the complaint? Difficulty swallowing, so which means kind of dysphagia, feeling like food is getting stuck in his throat. He also experiences occasional episodes of chest pain and heartburn. He says he also has eczema family history. What is the possible diagnosis? Eosinophilic esophagitis, GERD, achalasia, peptic ulcer disease, or H. pylori infection. What do you guys think? Okay. So the audience is divided. The thing is, okay, you guys are confused between eosinophilic esophagitis and GERD. That's what I've seen from the answers that you guys are giving. So let me explain why we're picking the right answer. Why are we going towards that? So as you can see here, this thing, the food is getting stuck in the throat. This is not associated with GERD. GERD is a reflex, okay, in which it would come back, like once the patient has swallowed it, once the patient has swallowed the food, it will he will burp back or come back, okay? That is your gastroesophageal reflux disease. But if the food is the feeling is like it's getting stuck in the throat. It's not even passing along, okay? They do not have dysphagia, remember? GERD patients do not have dysphagia. And then he also experiences occasional chest pain and heartburn. This could be, yeah, now this could be associated with your GERD. However, as you can see, this is this is the other symptoms can also have this. Then he says he has family history of eczema. Now, eczema is what? Autoimmune disease, right? Whenever patients have autoimmune diseases, they often come together. So if they have asthma, they might have eczema as well. And out of these, which one is the autoimmune disease? It is eosinophilic esophagitis. This thing, the food getting stuck. Why? Because your esophagus, it narrows down. It basically has rings. It will form rings inside it. So that's the reason when food is trying to pass through it, it will feel like it's getting stuck. Okay. And then the family history of eczema is even more pointing towards this eosinophilic esophagitis. So both of these, like dysphagia, food getting stuck in the throat, and eczema history, all three are pointing towards eosinophilic esophagitis as compared to the other diseases. GERD will not have these problems. Okay, achalasia will also not have difficulty swallowing or eczema history. Peptic ulcer disease will not have food getting stuck. And H. pylori infection will also present differently. It will also not have food getting stuck in the throat. Okay. Is it clear, all of you? Yes, so eosinophilic esophagitis. And then there is a very good article about eosinophilic esophagitis on ICGP. And then these are some of the causes which might be associated with esophageal eosinophilia. Okay. So this is what it will look like. You see concentric rings on endoscopy. How are you going to diagnose it basically? What you're going to do an endoscopy and you're going to take a biopsy. On that biopsy, you're going to see more than 15 eosinophils and eosinophilia, and this will not even get better after giving PPI trial. Because, whenever you give PPI trial to a GERD patient, he will get better. But even after giving PPI trial, the patient is saying, doctor, the food is still getting stuck in my throat. I still have dysphagia. I still get heartburn, which means this is not GERD. So these are the diagnostic criteria for this. So you have found out that there's no other cause of esophageal eosinophilia. There's PPIs are not working on this patient, and on endoscopy, there are more than 15 eosinophils present. Or the concentric rings, you see, these concentric rings will be seen on the endoscopy. So these all are pointing towards your eosinophilic esophagitis. Okay. Good. Yes. So basically the same thing in this article is mentioned. All the important things I have taken and pasted here for your ease, so that you don't have to go through all that. Okay. Is it clear so far, all of you? Okay, good. Now let's go for the next question. A 70-year-old female patient, now let's see, 70-year, pretty old, female patient presents to her primary care physician, so GP, with complaints of pain and stiffness in her shoulders, hips, neck, that has been slowly worsening over the last several months. She also experiences some fatigue and general malaise. She has also been having difficulty raising her arms and getting out of a chair. This is very suggestive, very suggestive. How would you treat her? Paracetamol, methotrexate, hydroxychloroquine, or prednisolone? Okay, first thing, I want to know what is the diagnosis here? Yeah, good. Yes, the diagnosis here is polymyalgia rheumatica. Yes, this is polymyalgia rheumatica, in which multiple muscles are involved in a fashion, and also rheumatic types features. So she has pain and stiffness, but in the larger limbs. Okay, so which in the larger joints, which are your shoulders, your hips, and your cervical region. Okay, and then they will also have morning stiffness present as well. Plus, she has general fatigue and malaise, and this difficulty raising her arms and getting out of the chair, which means the bigger muscles are also involved. So polymyalgia rheumatica is the problem here, diagnosis. And the treatment, ideal treatment for polymyalgia rheumatica is steroids. Out of these, which are the steroids? Prednisolone. So prednisolone is the treatment of choice. Yes, good. All of you are very smart, almost prepared for the exam already. Okay. So this is these are a couple of articles. As you can see, this is the diagnosis. So let's just go through this article and see. It's always beneficial to go through the articles and, you know, okay. So polymyalgia rheumatica, how to diagnose it and what is the management. Oh, okay, this is the article. Yes, so here, can you guys see it? Is it big enough? So common rheumatic disease that affects patients in middle age and older. Okay, its incidence increases progressively beyond the age of 50. Okay, then let's point towards the clinical features. So affects shoulder and hip girdles, causing aching and morning stiffness related to synovitis and proximal joints. So these are like our patient had shoulder and hip joint problem, okay, or stiffness. Then they will have morning stiffness present. Then they could also have distal musculoskeletal manifestations such as carpal tunnel syndrome. And then they might also develop peripheral arthritis. So this is what you'll be experiencing in a patient. Then bilateral shoulder pelvic girdle aching or both, morning stiffness, age older than 50, duration of more than 2 weeks. This is the diagnostic criteria for in order to label the patient with polymyalgia rheumatica. And then they should have high ESR and CRP. Okay, these are the diagnostic criteria that you must know. Other than that, there is no specific like criteria associated with it. Okay, then once you have done all this and you have done the ESR and everything, how to manage it? Management is, as you can see, corticosteroids. Once the diagnosis is established, the patient should be commenced on low-dose steroid therapy. The dose is then gradually tapered over time. It is important to counsel the patient about potential risk factors associated with long-term steroid therapy. So what is the diagnosis? What is the treatment? Prednisolone, which is you can see here. So all of these are here. So starting prednisolone doses, and then these are the doses that they're giving, daily prednisolone, or they sometimes give intramuscular methylprednisolone injections. So this is how you're going to treat the patient with polymyalgia rheumatica. Okay. Okay, Shanjada, what do you want me to highlight? Okay, so these are the, this is how you're going to treat your polymyalgia rheumatica. Let's get back to our slide. Yes, is it clear? I do have a couple of more articles. Let's see if there is something more beneficial. So this is again from our NPS Medicine Wise, Australian prescriber. So they're talking about polymyalgia rheumatica. It is the second most common autoimmune rheumatic disease after rheumatoid arthritis. Just good to know, nothing important. And then clinical features, yes, the very same way. So bilateral shoulder girdle pain, early morning stiffness, neck, back, or buttock, which is your hip joint and neck cervical region, just like our patient presented. Then again, for diagnosis, you only do CRP and ESR to know they both will be high. Then the diagnostic criteria, and after that, you're going to, this is a good article. This is a very good criteria in order to know how to label a patient with this. And after this, treatment is steroid. Okay. Yes, so these are a couple of articles to go through. Okay, good. Yes, so one of you is asking, how long are we going to give steroids? So steroid therapy is started as soon as a diagnosis is made. And then for 3 weeks, you're going to give them initially for 3 weeks, 15 mg. After that, you're going to give them 10 mg for 12 mg for the 3 weeks, then 4 to 6 weeks further 10 mg. And after that, you make it 1 mg, 4 to 8 weeks. This is a whole guideline, by the way, guys. You don't need to go through that, but just for your own like knowledge and all that, if you want to know, it's almost 1 year long therapy in which you're going to start at a higher dose of 15 mg, then you're going to taper it off, okay, till 1 mg, and after that you're going to stop it. Once the patient like symptoms are gone, okay. Okay, Julius is asking, do we need to memorize dose and duration for the exam? Not really, no. You like first, only there are a couple of medications for which you need to know the dose, which are very common ones, very common, and I would highlight. Like if you would join this course, I will definitely highlight what are those important doses that you need to know whenever we come across them. Like for example, we should, it's good to know what is the highest dose for olanzapine, okay, or risperidone, because they sometimes ask that in the exam, like they're saying that, okay, 20 mg olanzapine has been given, but the patient is still not getting better. And the options will be increased dose of olanzapine, or the other will be change it to clozapine. So you're going to change it to clozapine instead of increasing the dose, because of 20 mg to 30 mg is the highest dose of olanzapine. So they're not directly going to ask you about the dosage, but there are just a couple of medications for which it's good to know what will be the dosage that will help you with the answers, okay? Other than that, they don't ask you for that. Okay. So steroid is the main treatment for polymyalgia rheumatica, as we have all seen, discussed. Yes. So next question now. A 75-year-old male presents the, okay, age 75-year-old male presents to the ED with complaints of worsening shortness of breath, chest pain, fatigue for the past few days. Okay, so shortness of breath is present, chest pain and fatigue. He has history of hypertension, hyperlipidemia, and aortic stenosis with systolic gradient of 45 mmHg and ejection fraction of 35. What will be the treatment? I know it is kind of a complicated question, but I will explain. I will try my best to explain it to you guys, but I'm like, I wanted to incorporate all these questions in like in this class, because just so that you can have an idea of what to expect in the exam. You know, like one question is GIT, the other one is cardio, then we have ethics, then we have like, you know, mix and match screening going on. So it's good to go through these. So aortic valve replacement, percutaneous balloon valvuloplasty, CABG, or periodic monitoring. So what do you guys think is the answer? Let me see what you guys are saying. Okay, good, smart. All of you are getting the right answer. Yes, the answer is aortic valve replacement. Why are we going to do that? What's happening here? Basically, there is aortic stenosis going on, right? So aortic stenosis, in which systolic gradient is 45 mmHg. If systolic gradient is more than 40 mmHg, or in other words, we can say if it is more than 4, that is considered as severe aortic stenosis. Okay, and for severe aortic stenosis, we are going to go for aortic valve replacement. Ejection fraction 35 is also a bit like low, but that is not a big problem. It's considered in the normal range. So we are going to go for aortic valve replacement. Yes, it is a bit less, but it is a machine. It is a bit less ejection fraction, but it is not too less. Okay, it is not against surgery. Why do we need to know the ejection fraction? Because we want to know if the patient is a fit candidate for surgery or not, right? So if it is less than 30, then that would be a problem. Since it is 35, this patient can have surgery. Okay. So let's see these articles. So as you can see, aortic valve replacement by surgical aortic valve replacement. So there are two methods of doing it. Either you're going to do it surgically, or you're going to do it through transcatheter aortic valve replacement. So surgical or catheter, which is through your video assisted. So these are the only effective treatment for your severe aortic stenosis. So indications for aortic valve replacements are, and then this is how to identify it. This is severity and how to do that. Let me find if there is an article. Wait. Because there is an article in which it mentions how to check the severity. Yes. So this is the pathophysiology. This is the signs and symptoms. Yes, this is the one. So how to classify the aortic stenosis severity? Normally, the aortic gradient is less than 10. Okay, sorry, is less than 10, or in other words, you can say transaortic velocity less than 2, or aortic valve area 3 to 4. This is normal. Imagine like your aortic valve has to be wider. In stenosis, it will get narrow. If the area area is decreasing, but pressure gradient is increasing, because imagine in your own mind, if the area is less, it will require more pressure, more force to flow through that. That is the reason its pressure is high. So if the area is less, it will have like normal area is 3 to 4, or normal pressure gradient is less than 10. So here, as you can see, severe is more than 40 mmHg, and our patient had more than 45. So the treatment will be aortic valve replacement for severe aortic stenosis. Okay, so this is again a very good flow chart. I'm going to take some time to explain it. It is a bit difficult to understand, so I want your full attention on this one. So how to manage it? I will zoom in a bit as well. So aortic stenosis, if it is moderate, and the maximum transaortic velocity is 3 to 3.9, or this is 20 to 39, as you can see, the moderate one, 3 to 3.9 or 20 to 39, what are you going to do? If the patient is asymptomatic, then patient is already planning to undergo some other cardiac surgery. If yes, then with that cardiac surgery, we're going to do the aortic valve replacement. But if the patient is not planning to undergo any other cardiac surgery and he's just asymptomatic, then we're just going to monitor the patient, okay? But if the patient is symptomatic, in that situation, okay, now if the patient is symptomatic, in that situation, we are going to see left ventricular ejection fraction. If it is less than 50, then we are going to go for dobutamine stress echo with aortic valve of less than 1, or basically for the severe aortic stenosis, and we are going to see the stress dobutamine stress echo. And if it is positive, in which we come across that the area is less than 1 or velocity is more than 4, we are going to go for aortic valve replacement. But if dobutamine stress echo does not cause all these problems, then again, just periodic monitoring. But if the patient is symptomatic but has left ventricular ejection fraction of more than 50%, then aortic valve area of less than 6 and small left ventricular volume, if it is present, yes, aortic valve replacement. If no, then just periodic monitoring. However, on the other side, here, considering our patient, so if it is more than 4 or more than 40, we are going to see if the patient's symptoms are present or not. So if the symptoms are present, yes, aortic valve replacement without thinking anything else. Wherever you have like symptoms present with severe, you're going to undergo surgery. Then if the symptoms are not present, then we are going to see left ventricular ejection fraction. If it is less than 50, again, that's a problem. We are going to go for aortic valve replacement, right? If it is more than 50, if it is not less than 50, basically more than 50, then again, we're going to go for the risk assessment, if this patient is okay to undergo surgery or not, right? So then we're going to see if it is more than 60, and if transaortic velocity is more than 5, and the patient is low surgical risk, then we're going to go for aortic valve replacement. If no, then we are going to like go for like stress test and figure out what else we can do for this patient, because if ejection fraction is like very low, that could be a problem. So again, this is how you're going to see. So if it is unclear, test results, do the exercise stress. If exercise stress comes back positive, this is similar to this one, your dobutamine stress echo. In the same way, you're going to do the stress exercise stress test. If it comes back positive, aortic valve replacement. If no, periodic monitoring. So this is a flow chart. I've also pasted it on your PDF file and on your exam as well. Yeah. Okay. Kutsia is asking how to remember. Don't worry about it. Kutsia, this is not very, they don't ask in that much detail. Remember this table, and remember that if the patient has severe aortic stenosis or even moderate aortic stenosis and the patient is symptomatic, we are definitely going to go for surgery, aortic valve replacement. And if ejection fraction is very low, then periodic monitoring we will be doing periodic monitoring. Okay. Yes, Dr. Hamid, I just explained it. Like this is as much as you can remember. Plus, like of course, practice, because this is kind of a new question that appeared in the exam. So you guys better like it's just better to like memorize some of the important points. Like I said, like if it is severe and symptoms are present, without even thinking, you're going to go for aortic valve replacement, right? But if it is moderate and the patient is not symptomatic, then periodic monitoring is your answer. Okay. If the patient is symptomatic and ejection fraction is less than 50, you're going to go for valve replacement if he is low surgical risk. If no, then you're going to go for periodic monitoring. Okay. Read it a couple of times and you guys will remember this. I mean, that's the best I can do. Unfortunately, remembering is your job, your thing. So I don't know. Can you guys hear me? Am I still audible? Okay, good. Thank you. All of a sudden, everybody went quiet. I was like, what just happened? Okay. So I know this was a tough one. This was a lot to remember, a lot to go through. So unfortunately, you might come across such questions in the exam. So that's like the best that we can do is try to memorize as much as we can, and then just leave the rest on fate, or maybe just to the examiners. Maybe you'll find out in the exam. But that's like, try your best, try your hardest. That's why it's always very good to go through the maximum number of sample questions, so that you will have an idea of what to expect in the exam. You see, as we are going through the questions, some of them are very easy, very easy. You can click the answer in a minute, right? But some of them are like tricky, or some of them require extra knowledge, or like, you know, senior level knowledge. So this is how they differentiate between like very good star students and like average students. But again, in the end of the day, it's all about passing the exam. You don't need to, like, if somebody wants to, sure, they can talk the exam, but in the end of the day, the end goal is to pass the exam at the first go. So just be confident, just like go through these questions and again and again and again. Just keep an eye on, you know, what's the hot topic, what's being asked a lot, and keep yourself familiar. Find a good study partner and work with them. Plus, this course is very, very beneficial. Like if you would take it regularly, because we have devised a plan for you guys to go through maximum number of questions, all the theory topics and everything that is needed for this exam to keep you on track and to pass the exam in the first go. So that is the goal. Thank you. Okay, so let's move on to the next question. Okay. A 50-year-old male, so 50-year-old male presents to the ED with severe chest pain, vomiting, and shortness of breath. He reports severe retching and then projectile vomiting after drinking heavily. Upon examination, the patient is found to have a high fever, tachycardia, hypotension, and respiratory distress. A chest X-ray reveals the presence of mediastinal emphysema and left-sided pleural effusion. What is the diagnosis? Boerhaave syndrome, Mallory-Weiss syndrome, ruptured peptic ulcer, or ruptured aortic aneurysm? Yes. Very good, very good. See, now this question, everybody knows the answer. Yes, this is Boerhaave syndrome. How do we know? You see, the patient, first thing, he's presenting to the ED, and his symptoms are severe because severe chest pain, vomiting, shortness of breath. All of these are severe symptoms. And then he reports severe retching and then projectile vomiting after drinking heavily. Again, associated with, like what happens in Boerhaave syndrome, the patient will consume a lot of alcohol, and or maybe because of any reason, he would vomit severely. Severe vomit that would lead to the rupture of esophagus. So esophageal rupture is happening here. After that, once that will happen, the contents of esophagus will go all around into your mediastinum. So that's the reason the patient has developed fever and tachycardia, hypertension, and respiratory distress. Okay, and because now that the esophageal rupture has happened, it is located on your left side. Esophagus is like turning towards that because your stomach on toward a bit on the left. So left-sided pleural effusion is also associated with esophageal rupture because your left lung is right close to that. So that's the reason the patient will develop emphysema and left-sided pleural effusion. So the answer is Boerhaave syndrome. Okay. Yes. So yes, Boerhaave syndrome, and then I will explain it to you in this article. Sorry. Yes, can you guys see my screen? Oh, okay, can you see it now? Okay, great. So this is your Boerhaave syndrome. This is Radipedia, again, a very good website. You can go through this quite often in order to memorize things, because sometimes in the exam you will be coming across like your CT scans or your chest x-rays or things like that. So it's good to know all these things. Okay, so Boerhaave syndrome is basically what? Your esophageal rupture secondary to forceful vomiting and retching. So then clinical presentation is your Meckler's triad, which is vomiting, chest pain, and subcutaneous emphysema. This is often associated with it, but if it is not, do not just disregard it, okay? For example, if they do not mention subcutaneous emphysema in the exam, do not don't be like, okay, it can't be Boerhaave syndrome. It can still be Boerhaave syndrome, okay? Then other symptoms could be epigastric pain, back pain, dyspnea, and shock, okay? Then how are you going to see it on the exam? That is the important question, right? So here, as you can see here, this hole, like your lung is collapsed and there's emphysema. Yeah. As we go up and down, you'll be able to see it. This is just the up part. This is the lung happening. And then let me find some good X-ray that you might actually see in the exam, because I'm looking for an X-ray. Pleural effusion is more, okay. So other than that, yeah. A radiograph will show pneumomediastinum, left pleural effusion, and left pneumothorax. then sometimes you might see like Lydio V sign, which describes a focal sharply marginated region of paraspinal radiolucency on the left side immediately above the diaphragm. This is just basically a V type of sign which is present there. Okay, this is don't confuse it. They don't ask about it, so let's just ignore this. It's just an add-on information. If somebody wants to remember it, they can. Otherwise, it's not necessary. Then fluoroscopy is sometimes done, but they might give you a false negative result. And then CT scan is also done after that if the patient is stable. Do not go for CT if the patient is unstable. Never do that. And as you can see in our patient, the patient is not stable. So we're not going to go for CT. So how to treat it? Because this is a severe life-threatening situation. Okay, sepsis is happening. Then 35% is the mortality. So in this situation, what is the treatment? Surgery. Rupture has happened. How can you fix it? Open the patient, do laparotomy, and fix the the rupture, right? So there is an emergency use of conservative method, namely esophageal stenting. So sometimes a stent is also placed just to save the patient, just to get some time. Okay, so this is how you're going to treat the patient. Okay, and it is named after Hermann Boerhaave. I don't know if you want to know this or not, but yeah. Okay. So this is how you're going to see it. Okay, let me share my screen. Yes. So Meckler's triad, which is your vomiting, lower chest pain, subcutaneous emphysema. Then plain chest X-ray, 90% cases abnormal, which means you'll be able to see pleural effusion there. Then contrast enhanced CT scan is done as well. So management is conservative, endoscopic, or surgical. The best treatment, basically, what is the right treatment? Surgery. Okay. Sometimes, if the patient has not developed sepsis, you might want to and has presented to the emergency very early. Only in that situation, you might want to consider conservative management, or in a patient who's not suitable for surgery, right? Other than that, it is a life-threatening emergency. So cessation of oral intake, NG intubation, IV fluids, and parenteral nutrition is given. IV broad-spectrum antibiotics, PPIs, tube thoracocentesis. Basically, all of these, whatever you do in esophageal rupture is what you're going to do in Boerhaave syndrome. So then endoscopic bridging is temporary, sometimes in order to get some time. And also if the patient has a lot of comorbidities, like the patient is not suitable for surgery in that condition, endoscopic bridging is done. Otherwise, the important thing that you're going to do here is surgical intervention, okay? Which can either be open thoracotomy or video-assisted thoracoscopy. This is the treatment of choice for Boerhaave. Is it clear, all of you? Yeah, okay, again, a very, very good flow chart. So standard, this is what you're going to do. So immediately, nil by mouth, IV resuscitation is done, broad spectrum antibiotics started, and then ACE2 blockers are given. Next, you're going to see if the patient has sepsis or not, like the patient has developed a fever, tachycardia, tachypnea, and all those diaphoresis and those symptoms or not. If yes, then see if the patient's clinical condition allows surgery, which means he's suitable for surgery, immediately go for surgery, okay? What are you going to do there? Debridement and drainage of mediastinum, plus resection of thoracic esophagus with reconstruction if last year and extensive necrosis. So this is the management. But if there is no sepsis and the diagnosis is done within 24 hours, widespread mediastinal pleural contamination is present, again surgery. If not, then endoscopy plus minus pleural or mediastinal drainage. Now, if the diagnosis is made after 24 hours, you see 24 hours have been passed and the patient still does not have sepsis, right? So the patient is out of danger, kind of, you see? That's the reason we're not going for surgery at this moment. We are going to go for a conservative treatment. Somebody's mic is on.
Excuse me, doctor. Sorry to interrupt you. We can't see the screen.
You can't?
Yes, we can't. Sorry to interrupt you for that.
No,
but we all are messaging in the chat box.
Oh, okay. I was really focused on explaining, but wait a second, that's weird because on my, okay. Can you see it now?
Yes, thank you.
Oh, okay. I'm so sorry about that. I did not notice. I was so focusing on explaining it that I just, okay, great. So this is a flow chart that I've been explaining. Did you guys hear? Did you guys see what I was explaining? These were the conservative managements. This is endoscopic bridging, surgical intervention. Okay. Oh, sorry. So this is endoscopic bridging of the tear with self-expandable stent. So this is for the patients who are not suitable for surgery. And then for the main thing is thoracotomy or video-assisted thoracoscopy. Okay. And then next is standard treatment. This is the flow chart that I was explaining. So as soon as the patient with esophageal rupture presents to you, what are you going to do immediately? Immediately make the patient stop taking anything like null by mouth, start IV resuscitation and parenteral nutrition, give him broad spectrum antibiotics, and give him H2 receptor blockers. Okay, then you're going to see if the patient has sepsis or not. If sepsis is present, like the features of fever, tachycardia, tachypnea, diaphoresis, this means that the sepsis has developed, okay? So you're going to go for surgery. You're going to see if the patient is suitable for surgery. Yes, go for surgery immediately. What is the surgery? Open thoracotomy or video-assisted thoracoscopy, okay? And what are you going to do? This is what you're going to do. Debridement and drainage of mediastinum or pleural cavities with resection of thoracic esophagus with reconstruction if large tear and extensive necrosis, right? But if the patient is not suitable for surgery, endoscopy, right? But if it fails, there is no other option but to go for surgery, right? Now, if the patient have developed sepsis, there is no sepsis and the patient presents within 24 hours and you see that there is widespread mediastinal or pleural contamination, there is no choice but to do surgery, right? If there is no contamination or no widespread mediastinal like fluid leakage and all that, then go for endoscopy with pleural and with pleural or mediastinal drainage. Now, this is what I was explaining. If the diagnosis is made after 24 hours and the patient still hasn't developed sepsis, right? So if 24 hours have been passed, but still the patient is stable, this means that this patient is out of danger. Now we can go for conservative management, which is standard treatment. They might need mediastinal or pleural drainage, okay? If there is clinical improvement without mediastinal or pleural contamination, then continue conservative management. If not, endoscopy. And if endoscopy fails, surgery, right? So this is your Boerhaave syndrome and what to do. Okay, Trius is asking what can be the risk factor. So, like I explained, heavy drinking, vomiting, anything that can make a person vomit severely, anything. Could be intake of drugs, could be intake of like overdose on something, could be like alcohol intake, a lot of alcohol intake, could be any of the other, like, you know, bulimia nervosa and all that can also lead to this. So all of these can happen. Okay, Wrinkle, do you understand it now? You were asking me to explain it, to repeat it? Thank you, Machine. Okay, great. So let's go for the next question now. Okay, so this is, again, this is what you can see. This is how it will look like. So this is your pleural effusion happening, and this was the rupture, and it is like the whole mediastinum. It will, your esophagus, it will rupture and fluid will leak in the whole mediastinum. Okay. Good. Okay, next question. 1 week history of upper respiratory tract infection, where the patient was given amoxicillin but did not respond. On this presentation, there is a white coating on enlarged tonsils and there is generalized adenopathy. He has fever and muscle aches. A generalized maculopapular rash is also noticed. What will you do? Stop antibiotics, give budesonide, give methylprednisolone, IV fluid, or continue amoxicillin for 1 more week. Now, the patient has 1 week history of upper respiratory tract infection, and he has been taking amoxicillin, but it is not working for him. And now, when you examine the throat, it has a white coating, large tonsils, and generalized adenopathy. So again, he has fever in muscles, and then there's maculopapular rash. Okay, so what do you guys think? Yes, very good. Because what is the diagnosis? Why are we stopping the antibiotic? Yes, yes, Nashim, very good. This is infectious mononucleosis because of EBV virus. Yeah, yes. So we are going to stop the antibiotics because it is EBV, which is a viral disease. Viral disease is not going to respond to antibiotics, and it might get worse by developing maculopapular rash, right? So that's why stop the antibiotics is the right option. So let's go for these articles. So this is your infectious mononucleosis, and these are the cause is like it is called the kissing disease, it is called, and it is caused by saliva and close contact. Okay, now age is very important, even though we did not have an age given for this patient, but just remember it is in the teenagers. More commonly, it is in the teenagers. Okay, so now you see, mono may begin slowly, fatigue, headache, sore throat. The sore throat slowly gets worse, like in our patient. Tonsils become swollen and develop a whitish yellow covering. Often the lymph nodes in the neck are swollen and painful. Very similar to what is happening in our patient. Pink or measles-like rash can occur and is more likely if you take the medicine such as ampicillin or amoxicillin. See? So these are the symptoms: drowsiness, fever, loss of appetite, muscle ache, stiffness, rash, sore throat, or swollen lymph nodes. Other than that, these things can also happen, but these are uncommon, so you don't need to go through that. And yes, so sometimes they might ask you about the test that you want to do. Even though it is a clinical diagnosis, you are going to examine the patient, so you will see swollen lymph nodes, swollen tonsils with yellow-white covering, swollen liver or spleen sometimes, and skin rash. But if they want to ask the blood test, that is your monospot test or antibody titer test. So monospot will be positive for IM, and antibody will tell the difference between current and past infection, right? And what is the treatment? Actually, no treatment because it is a viral disease. So for viral disease, what are you going to do? Take rest, drink a lot of fluids, gargle with salt, water, and all that. And that's it. And for the symptomatic relief for pain and fever, acetaminophen or ibuprofen. So your paracetamol or brufen will be given. Okay. Yeah, investigation of choice, Cheyenne, is a monospot test, or sometimes you may want monospot test is the investigation of choice if they want to ask you. Okay. And then there is this article, glandular fever. Yeah, okay, there is another name for it, remember, guys, because sometimes it could be infectious mononucleosis, it could be kissing disease, it could be EBV, it could be glandular fever. So what is glandular fever? It is again caused by EBV, more common in teenagers and young adults. Same symptoms: fever, swollen lymph nodes, sore throat, loss of appetite, abdominal pain, and jaundice might also be present. Then rash might also appear. Okay, so this is what you're going to see. How to diagnose it? Like I said, clinical diagnosis. But sometimes if they ask in the exam, pick monospot test. Okay, and treatment is just relieve the pain and fever. So your paracetamol and your brufen is the ideal treatment of choice. Okay, Nipat is asking, if asked next investigation after symptoms. Okay, if they're asking for the confirmatory investigation, go for monospot test. And if they want to know if it is a current infection or a past infection, then antibody titer is the best investigation. Okay, Rabel is asking how can we differentiate it from tonsillitis? Tonsillitis is a very, very broad term. If you're talking about strep throat, which is your streptococcus, which is called by streptococcus bacteria, well, they will respond to antibiotic. They will have, they will not have enlargement of spleen, or they will not have jaundice. Also, their symptoms will be worse in the beginning and they will get better with the passage of time. But with infectious mononucleosis, initially the symptoms will be mild, but with the passage of time, they will get a bit worse before getting better, okay? So this is how you're going to differentiate it. Great. So, okay. Can you guys see my screen? Okay, great. So this is, again, I have written the same thing that we did there, that this is how to treat this patient. So what are the symptoms? So these are the symptoms that we have discussed, and the treatment is no specific treatment, just something for fever and pain, which is your acetaminophen and your ibuprofen. Okay, is it clear, you guys? Okay, great. Next question. So John, a 38-year, okay, so 38-year-old male diagnosed with paranoid schizophrenia. He was initially started on olanzapine 10 mg per day, but taking it the last 6 weeks, John's positive and negative symptoms have not improved. Okay, remember guys, when you're asking about the dosages, this is the type of questions that you might see in the exam. Okay, so 10 mg, but he taking it for the last 6 weeks, the symptoms have not been improved. The dose of olanzapine was increased to 30 mg per day. However, after 12 weeks, John reports no improvement in his symptoms. He's then started on risperidone for 4 mg per day, still no improvement. What should be done next? Change to clozapine, increase olanzapine, add haloperidol, add benzodiazepine. What is the diagnosis? Yes, guys, what is the diagnosis? Yes, this is treatment-resistant schizophrenia. Yes, so that's the reason. Yeah, so whenever, how do we establish the diagnosis for this? When 2 of the antipsychotics are given, 2 of atypical antipsychotics are given, but the patient is not responding to both of them, then, and we have waited for 12 weeks. So basically, at least 3 months, the treatment should be continued, okay? And the patient does not improve, then we call it treatment-resistant schizophrenia or drug-resistant schizophrenia, and we start clozapine. Clozapine is a drug of choice for treatment-resistant schizophrenia, okay? So please remember, it has to be 2 medications. If they would not have mentioned this one, like the patient was not started on risperidone, then we could have gone for risperidone, change it to risperidone, okay? But since both of them have been given and still the patient is not improving, we're going to go for clozapine now, okay? So change to clozapine because it is drug-resistant or treatment-resistant schizophrenia. 30 mg is the maximum dose of olanzapine, so you can't increase it anymore, right? And drug-resistant schizophrenia, when the patient does not respond to 2 different antipsychotics. This is your drug-resistant, right? So let's go through this article. So, adults with schizophrenia that has not responded adequately to treatment with at least 2 antipsychotics, at least of one which should be a non-clozapine, 2nd generation antipsychotics are offered clozapine, right? So this is your answer. Like 2 antipsychotics, at least one of them should be 2nd generation or atypical. So even if the patient has been tried on haloperidol and olanzapine, or so then we're going to give that. 4 mg. Max dose of risperidone is 4 milligrams. Okay. So this is your answer. Let's get back to our slides. You guys can see the screen, right? Now I'm a bit paranoid about it, that all of you are able to see it. Yes, Stuart, that's correct. If the patient still does not respond to clozapine, the last resort is ECT. That's correct. I was about to explain that part. Okay, so drug-resistant schizophrenia. This is what I've taken from JM8th edition. Page number is 836 for your reference. So once you have seen all this, ECT may help agitated patient. If the patient is catatonic, consider a trial of clozapine initially, increase it to 200 to 600 mg/d. See, so start with 12.5, and you can increase it to 600 mg daily, with strict monitoring for bloody dyscarrias and cardiotoxicity or olanzapine 5 to 20 mg, and then a trial of adjunctive ECT. So basically, what's the flowchart? What are they talking about? They're saying if the patient is not responding to atypical antipsychotics, you're going to label it as drug-resistant schizophrenia, and you're going to give the patient a trial of clozapine. If the clozapine has been trialed and tested to its maximum dose, but still the patient is not responding, last resort is ECT, right? Is it clear, you guys? Okay, great, thank you. So next question is, what kind of study a student will do to check the efficacy of vitamin C supplementation in control of hypertension? Now, this is an ethics question, not ethics, like, epidemiology and biostat question. So, yeah. So, RCT, cohort, cross-sectional, case control, or blind end studies. Yes, very good. RCT, randomized control trials. Now, let me tell you why we do that. Basically, here they were asking for the efficacy of a drug. Okay, so there are two types of studies: observational and your interventional studies. So in observational studies, we just look at the patterns, like your cohort, cross-sectional, and like your cohort, case control, and cross-sectional studies. These three are your observational studies. Here we study only the disease patterns, either in the future or in the past. So, but when we do intervention, like for example, we introduce a process, treatment, a drug or something like that, we are doing an intervention that comes into your randomized control trials. Okay, interventional, best one is your RCT. So here, because the student wants to check the efficacy of vitamin C, which means efficacy of a drug or a treatment, so RCT is your best choice. Yes, good. So these are your observational studies and interventional studies where we interfere by providing either medication or treatment. And the best one is your randomized control trials. So RCT is considered the gold standard design for examining the effectiveness of a patient. And randomized control trials are well conducted, remain the gold standard for the evidence of efficacy. So again, whenever you want to study efficacy as well, this is the best thing. This is the best trial that you can use, which is RCT. Let me just show you this article. So as it's written here, you guys can see it, right? Randomized control trial is the gold standard design for examining the effectiveness of a treatment. Here, and again in the other one as well. So efficacy and effectiveness and efficiency, here they're just like differentiating these things. Like efficacy is not the same as effectiveness. A treatment is effective if it works in real life and not in non-ideal circumstances, right? But efficacy is something that is working in an ideal situation. So I hope you guys understand the difference and like how to pick this one. I'm really glad that all of you picked the right answer, to be honest, because like the previous class was confused about this. Okay, is it clear, all of you? Everyone, is it clear? Okay, great. So let's move on to the next question. Yeah, an elderly man with hearing aids and bilateral cerumen impaction, positive bilateral Rene test, and Weber's is lateralized to the right ear. What is the diagnosis? Conductive hearing loss to the right, sensory neural hearing loss in the left ear, bilateral acoustic neuroma, or otosclerosis. What do you guys think? Very good. All of you are getting it right. I'm impressed. Yes, this is sensory neural hearing loss in the left ear. Well, now let's see how many of you know that what's the difference, because okay, they say positive Rene test. Whenever they say positive means Rene test is normal, okay, which means there is no conductive hearing loss. When Rene test is normal, you do not have any conductive hearing loss. The only problem is your Weber, and Weber is mostly pointing towards your sensory neural hearing loss, right? So sensory neural hearing loss is the problem here. And if it is lateralizing to your right, it should lateralize to your normal ear, right? So normal ear is right, so the problem should be in left ear, okay? You get it? Yes, good. So that's why the answer is sensory neural hearing loss in the left ear. Good. So here, this was the answer. Normal hearing. So both Weber test and Rene test will be normal. So here, as you can see, people, okay, most of the people, they get confused about positive. They hear the term positive in a test and they think that this is problematic. This is wrong. But Rene test positive means normal. I just want you to remember this, okay? So when normal hearing, both of these will be normal. In unilateral sensory neural hearing loss, Weber will lateralize to the unaffected ear. In other words, it is heard louder in the better ear, like our patient. Weber was lateralized towards right, right? Weber was lateralizing towards right, which means the sensory neural hearing loss was in the left ear, right? So left ear was the problem. Rene test is normal or positive on the affected ear, denotes air conduction better than bone conduction. So whenever Rene test is normal or positive, what does it mean? Your air conduction is better than your bone conduction, okay? So unilateral conductive hearing loss, when you're thinking of conductive, Rene will be abnormal or negative, right? Which means bone conduction greater than air conduction, but Weber will lateralize to the affected ear. Remember this, the difference. If it is only sensory neural hearing loss, Weber will lateralize towards unaffected ear. If it is conductive hearing loss, Weber will lateralize towards your affected ear. So here, Rene is abnormal and Weber is lateralizing towards affected ear, okay? And when you have symmetrical conductive hearing loss, Weber does not demonstrate lateralization and Rene test will be abnormal or negative. Is it clear? Okay, good. So this is just another way. Yeah, this is something that you should know when you're thinking about sensory neural hearing loss, because sensory neural hearing loss can be associated, like what are the different diseases that are associated with this? So it could be presbycusis, it could be noise-induced, autoimmune, parietal fistula, Meniere's, and acoustic neuroma. So all of these are because of sensory neural hearing loss, okay? So if it is gradual, presbycusis, right? If it is caused by noise exposure and gradual, noise induced. If it is rapidly progressive, autoimmune, and it is bilateral as well, okay? If it is sudden but unilateral, it is perilymph. If it is sudden unilateral, but this triad, tinnitus, episodic vertigo, and you have hearing loss, Meniere's. And if it is gradual with tinnitus, it is acoustic neuroma. So these are the different types of sensorineural hearing losses that are associated. I will explain it to you. Yes, Nasheen. How is presbycusis and autosclerosis? So here, autosclerosis is your conductive loss. Okay, presbycusis is your sensorineural hearing loss. Both are very different. Presbycusis, sensorineural. But autosclerosis, this is your conductive hearing loss. It is an autoimmune inflammatory disorder. And it could be because of measles, could be because of anti-collagen autoimmunity, inflammation, bone loss, organotropism, hormonal or metabolic factors. What will happen? The patient will be unable to hear low-pitched sounds or can't hear whisper. So if you're talking slowly, the patient won't be able to hear, okay? And also sometimes it might be associated with dizziness and balance problems. And what is the gold standard investigation? Non-contrast CT. Is it clear? Nasheen, is it clear? How is it different? Good. Okay, great. So let's look at this article. This is again about autosclerosis, just to give you a bit more insight in it. So symptoms are gradual but progressive hearing loss and ringing in the ears, and dizziness might also be present. It might be associated with pregnancy, by the way, guys. So this is an important thing to know for the exam. Measles and all those things, osteogenesis imperfecta, and how to diagnose it, hearing tests. So on hearing tests, just like we said, because it is conductive, so Renee will be abnormal or negative, right? So you will have either conductive or mixed hearing loss, right? Treatment, medication, hearing aids, or surgery. Okay. Yes, so in autosclerosis, Renee will be negative. Yes, because it is conductive hearing loss. And presbycusis is presbycusis is your sensorineural. So sensorineural is basically your nerves problem, right? It's not like ear structure or something like that. It's because of the transmission of ear and like nerves and all that. So it's happening because of that. Cheyenne? Oh, Weber in autosclerosis will be lateralized towards affected ear. Machine, Weber will be lateralized towards the affected ear. Okay, just like we discussed. Okay, great. Is clear? Is it clear now, everybody? Any other questions about this? Okay, great. Thank you. Let's move forward to the next. I have again added just a couple of more tables for you guys' convenience. And also this article is very good on how to interpret Renee and Weber test. So you can go through this as well. But I have basically tried to simplify it as much as I can. Okay, so conductive hearing loss heard in the bad ear, so heard in the midline, and certainly heard in the good ear. So this is how it will work. Okay, so is it clear? Right? It's all clear. Let's go for the next question. So, while playing basketball, a 23-year-old man landed on his foot awkwardly and injured his ankle. He's in the emergency department now. On examination, lateral dislocation of the ankle is evident. Okay, so he's a basketball player, he's 23 years old, and because he landed on his foot awkwardly and injured his ankle, now where he is? In the ED. Lateral dislocation of ankle is evident, dorsal pedis pulse is absent. That's problematic. And the foot looks pale and cold to touch. Which one of the following would be the next step in management? Reduce the dislocation in emergency department, send the patient to operating room for reduction under general anesthesia, immobilize the joint with plaster, send the patient to the operating room for open reduction and internal fixation, or angiography. What do you guys think? Ooh, so many answers before I finish the question. That's amazing. Okay, yes. So let me explain why we are picking the answers. Reduce the dislocation in emergency department because this is acute limb ischemia. What's happening? You see, dorsalis pedis pulse is absent and foot looks pale, which means because of the dislocation, the neurovascular bundle is displaced. Okay, because the bone is displaced, the neurovascular bundle is displaced. That is why the blood supply to the foot is lost. So here you cannot wait for the patient to go to the ER, to the OR, or to immobilize, or to go for open reduction, or basically anything. This is critical. This is like limb threatening. If you do not do any intervention right now, right there and then, you are going to lose the limb. So immediately, without waiting for anything else, without like, even if you do not have like those sanitary measures or like hygienic measures, you have to save the foot. Okay, so you're going to reduce the dislocation in the emergency department. You cannot wait for the patient to go to the OR and reduce it under general anesthesia. You do not have time. By then, you will lose the limb, you will lose the foot, right? And you cannot immobilize, because immobilization is going to do no good, right? It's not the point. You have to dislocate it to restart the blood supply to the foot, right? That's the problem here. The problem here is not, this is not an ortho question, guys. Remember, this question is emergency. They want you to know that this is acute limb ischemia, and what to do next is reduce the dislocation in emergency. So again, send the patient to operating room, not a feasible option here, because this is going to take time. All these other options are going to take time. So the best thing to do here is you're going to go for reduce the dislocation in the emergency department. Okay. Is it clear, guys? All of you? Okay, good. So reduce the dislocation in the ED. So here again, pre-hospital reduction, they're saying you're not supposed to do pre-hospital reduction unless neurovascular compromise is evident. So even if the patient is not in the ED, for example, even if you're the first responders, you're paramedics, and you're the people driving the ambulance, and you're being called, and you go there and you see that the patient's dorsalis pedis pulse is absent and the foot is pale, you're going to reduce the fracture right there in the field. Okay, so pre-hospital, before reaching the hospital, you're even allowed to do that only when there is neurovascular compromise that is present of cool dusky foot. Okay, and there is prolonged transport time. So in these situations, you can even do that in the field without even OR. If neurovascular status of extremity is compromised, the fracture should be reduced as soon as possible, and reduction should be maintained during the healing period with a cast, external fixator, or open reduction. So first thing is reducing the fracture. After that, whatever has happened, you can fix that either by a cast, fixator, or open reduction. Okay. So these are just a couple of articles about how to do that. Let me open this one for you guys. Okay, it is the same thing that I discussed. Yes, so, okay, is it clear, all of you, why we're doing what we're doing? Like, why are we reducing it in the field? Yes, okay, good. Next question is, a 33-year-old male presented with the right hypochondrial pain, jaundice, and fever. He is also anemic. LFTs are deranged. He also has gait instability and clumsiness of both hands. On examination, fever is 38.9, so quite high, yellowish discoloration of the skin and dark colored urine, case of facial ring 3 mm in diameter. What is the investigation of choice? First thing, please tell me what is the diagnosis here? What do you guys think is the diagnosis? Okay, Rabel is asking if there's nothing wrong with the blood supply. Yes, if the blood supply is fine, then you do an X-ray And on that X-ray, you're going to call ortho department, orthopedic registrar or orthopedic SR, and you're going to consult them. And if they want to reduce that, like based on the amount of fracture, like if it is a linear fracture, if it is like a compound fracture, complex fracture, based on that, you're going to do the management. So it will either be just a cast application, or it could be internal fixation or and open reduction, or it could be like just immobilization, depending on that. Okay. Yes, very good, excellent. All of you are right. This is Wilson's disease. Yes. So in Wilson's disease, what happens is excessive copper will get accumulated in your body. So excessive copper will cause all these liver problems. It will cause because it is getting into the neurons in brain. So you will have like neurological problems like gait instability, clumsiness of both hands, and also you will have jaundice. Very important, very differentiating feature, case of Fleischer ring will be present, which is very suggestive for your Wilson's disease. And the investigation of choice, as you guys all said, is serum copper and serum ceruloplasmin levels will be assessed and checked on this patient. Very good. Okay. So of course, because it is so straightforward, you're not going to go for any ultrasound of liver or abdominal CT, PTA, PTT, or full blood count. What is the investigation? Because they're asking investigation of choice. So the investigation of choice is serum copper and ceruloplasmin. Okay, and this is your case of Fleischer ring, as you guys can see. This is this ring, which is surrounding your cornea, is your case of Fleischer ring. Okay. So let's go for this. Article. So this is your Wilson's disease. So what can you expect? Most of the people appear individuals ranging from 3 years to over 50 years of age. And what are the symptoms? Enlarged abdomen, which is abdominal ascites or something like that will be present, abdominal pain, loss of appetite, vomiting of blood, or sometimes like hyperemesis, and splenomegaly, jaundice, hand tremors, stiffness and reduced movement of extremities, because copper will also accumulate in the joints. So that's why they will have joint stiffness. Movement of the body is jerky, slow, and difficult to control. This is again neurological, together with hand tremors, speech difficulties, personality changes, neurological. Symptoms of mental illness, such as depression and homicidal tendencies, lack of menstruation or amenorrhea, confusion, and dementia. So these are the symptoms. Now, causes could be, of course, enzyme problem, because copper needs to be, because the enzyme which is required for the storage of copper is not working fine. If there's like genetic mutation, because it is autosomal recessive. So that's the reason, because of that genetic mutation defect, the enzyme is not storing copper. The enzyme is not able to store it properly. So it is like everywhere. It is accumulating everywhere. So that's the reason the patients will develop it. And then complications is, as we know, because it is accumulating in the liver, so it can cause hepatitis, cirrhosis, necrosis. It can also, of course, decrease your immunity, spleen disorders, anemia, muscle atrophy, all that. We all know what can happen. How to diagnose it? Yes, so physical examination, eye examination for a case of Fleischer ring, this. Blood test, urine test, plus of course coppers and ceruloplasmin levels, which is the most important test. Then you want to go for genetic testing if it is required. And what do you see? ATP7B gene. So this is the problem. This gene is mutated. How to treat it? Vitamin B6, potassium supplements, zinc therapy, and low copper diet, chelation therapy with penicillamine. Okay, regular blood and urine checkup and all that, low liver transplant and severe cases and all that. So this is how you're going to treat the patient with Wilson's disease. So again, here, as you can see, same thing is happening. So this is how you're going to, here. The main way to diagnose is ceruloplasmin level and copper level, right? And then treatment again, as we have discussed. Is it clear, all of you? Okay, so Cheyenne is asking, serum copper levels will increase. Yes, serum copper levels will be very high. And what will happen to the level of ceruloplasmin? Ceruloplasmin will be low. Okay, anybody else? Anybody else got a question? Okay, let's go further next. So again, this is the main way, this is how you're going to, the main way to diagnose the disease is through blood test, as we discussed. So protein ceruloplasmin, this is a protein that basically that is used for copper transport. It will be low and your copper levels will be high. So here, as you can see, it's low. So case of Fisher rings, neurological signs, low ceruloplasmin levels. This is how you're going to diagnose it. Gold standard of diagnosis is copper content of liver biopsy. If they ask for the gold investigation, gold standard investigation on liver biopsy, you will check copper content, right? But this is like very, very, very last stage, of course. Like you don't do biopsy in every other patient. All right. So next question, probably this will be our last question for today. So Mr. Smith, 67 years old, retired school teacher, presents to the GP with the complaints of difficulty in writing, acalculia, and arithmetic function. He also reports confusion in distinguishing his left from his right. On examination, Mr. Smith is alert and attentive, but notably has difficulty in writing and spelling simple phrases and equations. He also struggles with simple arithmetic and has difficulty recognizing his own fingers on command. What could be the cause of this presentation? Cerebellar vermis stroke, left parietal stroke, frontal stroke, or occipital stroke? What do you guys think? Wow, all of you got it right. Nice. This is left parietal stroke. This is very, very, very specific, guys, because left parietal lobe is associated with writing and mathematics, basically all your arithmetics and mathematics, plus also distinguishing from your left to the right. So this is very characteristic. I'm very glad that all of you got it right. This is your Gerstmann syndrome. So Gerstmann syndrome is a cognitive impairment that results from damage to a specific area of the brain called left parietal lobe. So in the angular gyrus, what will happen? Look at the 4 primary symptoms: writing disability, agraphia or dysgraphia, lack of understanding of the rules of calculation, then arithmetic. Basically, the person cannot do maths. So acalculia or dyscalculia. An inability to distinguish right from left, and inability to identify fingers or finger agnosia. So these are the conditions that are associated with your Gerstmann syndrome, which might be associated with left parietal lobe stroke, right? So it could be because of focal lesions or ischemic. So ischemic stroke, tumor, aneurysm, carotid artery or middle cerebral artery. These could be a cause of left parietal stroke, right? Or Gerstmann syndrome, okay? And then these are some of the articles that are associated with different types of vessels. Let me share the screen. So here, as you can see, these are like different parts of the brain which are involved with different functions. So of course, if you open this article, you'll be able to see. What I tried to do was basically, I tried to accumulate all the different types of stroke and their presentation. So as you can see, if it is middle cerebral artery stroke, it will cause hemiplegia, contralateral sensory loss in the same area, and contralateral homonymous hemianopia. So middle cerebral will also affect your vision and will affect like hemiplegia, so paralysis will be happening where contralateral side, and contralateral sensory loss will also be happening, okay? So this is MCA. And then if it is anterior cerebral artery, you'll be able to see contralateral like weakness and sensory loss, right? If it is posterior cerebral artery, then you'll be able to see that there is vision problems, which is your contralateral homonymous hemianopia will be present here. Okay, so these are some of the defects which will be associated with this. In the same way, cerebellar strokes, you will have ataxia, of course, cerebellum, balance. So impairment in balance and coordination will be the main sign. Other than that, you know, like he cannot do those rapid finger movements of touching the nose and all that. There will be unable to move the finger in the straight line, and these will be associated with cerebellar. If it is brainstem stroke, this is a severe form, of course. So the patient will be unable to feel the half of the body, and it depends basically if it is hemiplegia, if it is quadriplegia. So like it can even be the whole body. So this is very rare, but this is the most severe one. Okay, so it will cause hemiparesis or quadriplegia, sensory loss affecting either side of the body again, double vision, disconjugate gaze, slurred speech, impaired swallowing, decreased level of consciousness, and abnormal respiration. So see, the patient will be in severe, like this is the stroke where the patient is like, this is the worst one, right? So he will require emergency intubation and mechanical ventilation. Right? So these are just some type of strokes. Unfortunately, we're out of time. However, I have listed these like these websites for you guys to remember and to go through just in case like you want to know more about it. So if you have any questions, let's talk about them now. Yes, everybody. Left parietal, which area is affected when there is difficult in intubation of speech? Initiation of speech. Speech initiation is also associated with left, but sometimes right parietal lobe will also be associated with it. But this is mainly a feature of parietal lobe. No worries. Okay, so I hope you guys had a good session with me today, and I'm hoping to see all of you in our next batch. There's a lot more to learn, and there's a lot more questions coming in. So I hope you guys learned a lot from this, and I will really appreciate your feedback about today's lesson. And again, a very good luck to all of you for your AMC journey, because I know this can take a toll on you. This is a tough journey, and it's a long one. So stay persistent, keep going, and have a schedule for every day. Just learn whatever you learn, you revise it, make sure you go through all the recent questions and consolidate your knowledge that you have learned so far. And just good luck to all of you, and hopefully all of you will pass in the first go. So thank you so much, everyone. I will be stopping the recording, and will also yes, so I will also